Thank you.
So we welcome Dr. Vishali Gupta. He's from, all of you know Dr. Vishali Gupta.
Thank you, Dr. Suresh. So basically, I think, sorry, I could not give this talk during the glaucoma session, but primarily you have to understand that angle closure is a very important part and parcel of the diseases we see in the eye. And as I teach to my residents, if you have to be a good glaucoma specialist, there are three important things that you need to know. You have to need your optic disc evaluation very well. You have to understand what is the management of angle closure, and finally you are able to do a good trabeculectomy. I think these three things would make you a good glaucoma specialist. So why is angle closure so important about in our country? Primarily because the prevalence of this disease is pretty high in our population. We are just next to China and the east of Asia as far as the prevalence of angle closure in our country is concerned. So the most important thing that you look for in angle closure is an occludable angle, right? And how do you define an occludable angle? Anything where you cannot see more than 180 degrees of the trabecular meshwork, and that too in the primary position. So I believe all of you have gonioscopes and you do a gonioscopy, because it's important as a resident to own a gonioscope, okay, and to be able to do a gonioscopy. And this recess, again, it is called a recess of the angle, and this should be less than 20 degrees. Okay, so you should be able to do enough gonioscopies to understand what is occludability, okay, and to write whether the recess is occludable, that is, it is less than 20 degrees or more than 20 degrees. And the third important thing that you need to know when you are looking for occludability is the extent of occludability. Okay, so it should be more than 180 degrees. So this occludability could be either because of a pupillary block mechanism, which is predominant, or it could also be because of non-pupillary block mechanisms. So it's important to differentiate the two, because your iridotomy is only going to work for a pupillary block, right? It's not going to work for non-pupillary block mechanisms. So if you're going to advise an iridotomy, you're only going to do it if you find a pupillary block, right? But on gonioscopy, you will find all of the angles to be occludable, irrespective of it's a pupillary block or a non-pupillary block. So the whole idea of this teaching exercise is for you to be able to identify what is a pupillary block and what is not a pupillary block. So if you look at this angle, it is occludable, right? You can see that on gonioscopy, the light beam is bending and you cannot see any structures of the angle. So it's a 0, 0, 0 angle. There is nothing that you can see. But now, in this particular angle, you can see some structures, okay? You can probably see the anterior part of the trabecular meshwork, and then now you can start seeing the posterior part of the trabecular meshwork. So therefore, the angle recess also in a particular patient varies, okay? In some patient, it might be totally occludable. In some patients, when you put in a gonioscope, you can see some amount of occludability, but you give a little bit of pressure and probably the angle will open up totally, okay? So you write that it's a 0, 0 angle. It's a convex iris configuration, right? But that 0 degrees is opening on indentation to almost like a full open angle, which is 30 degrees or so, right? So that is what we expect a resident to be able to tell us. So as I said, this is what you're going to see on an ultrasound biomicroscopy. So it's a pupillary block, okay, or it's a plateau iris, right? Or there's something pushing from behind, right? In which case it is uniformly shallow. The anterior chamber is uniformly shallow. And that could be because of a thick lens, increased lens vault, or there could be some uveal effusion which is kind of pushing it anteriorly, right? Here you can see on an ASOCT, you can see increased lens vault. Do you know how much is a normal lens vault? Anyone? Millimeters? Are you talking of, we are talking of microns. I think you have to know this. Are you, which year are you in? No, anterior lens, the lens vault, do you know how it is calculated? Tell me, someone, bolo? So you take, on an ASOCT, you take a line from the ciliary body to the ciliary body, right? And and you take it, then you take a perpendicular from the highest point of the anterior curvature of the lens to that horizontal line, and that is the in microns is the lens wall. So normally it is about 500 microns or less, but anything more than that would be an abnormally increased lens vault, right? So that is one thing. So lens vault, increased lens vault could be another cause of an angle closure, right? And or there could be an effusion, a choroidal thickening in some certain cases, which could also contribute to the whole iris lens diaphragm being shifted anteriorly. So apart from pupillary block, the next important mechanism is a plateau iris. And a plateau iris, you can just put in a gonioscope and you can see the sine wave configuration. When you see that configuration of the iris, it's like a sine wave, right? So that is a plateau iris which you can pick up as a cause of angle closure. So Foster gave an epidemiological classification where he classified angle closure as a suspect. Okay, that means there's just occludability and there's nothing else. Whereas an angle closure stage was one where, apart from occludability, there was some organic change of the trabecular meshwork in the form of synechiae or a high iris insertion, or there could be an increased intraocular pressure. Okay, so from a primary angle closure suspect, now the patient has gone into a primary angle closure stage once the IOP has risen. But again, there are no disc changes, okay, and of course there are no visual field changes either. And then is the final stage where this glaucomatous optic neuropathy sets in. In our population, there is about 40 years of age, there are 20 million and above patients are roaming around with some amount of occludability of the angle. Okay, majority of them are suspects. Some of them are angle closures, and of course a very few of them are going into an angle closure glaucoma stage. So the important question that comes to your mind is, when you're treating these eyes, are you going to do iridotomy for all of them? There are 20 million there roaming around with angle closure. The answer is no. And so we will go ahead and tell you in which cases will you do. So a primary angle closure suspect is a patient who's coming to you where on a torchlight examination someone has shown a occludable angle, right? Or, has shown a shallow anterior chamber and someone has put in a gonioscope and found an occludability of the angle. But the question is that there are so many of them, 20 million people roaming around with an occludable angle. We don't do an iridotomy in all of them, okay? And we don't even know how many of these occludable angles will go on to develop a next stage, which is angle closure, and the further next stage, which is an angle closure glaucoma. And if you read some of the current studies, you would realize that if there are about 100 or 1,000 of such patients, maybe only one of them would actually go on to develop a angle closure glaucoma or an acute attack. So the numbers actually going into the next stage are very few. So which means that you do not treat all of them. Then there are certain eyes where even after doing an iridotomy, you are not going to relieve anything, because the iridotomy is only going to relieve a pupillary block. It's not going to relieve an increased lens vault or a thick lens or an anteriorly placed lens. It's not going to relieve when the uveal tissue itself is thick, okay? And of course, once the total synechial closure has happened, the iridotomy is not going to relieve that either. So therefore, you have to be very wise in which patients you're going to do an iridotomy. So as I said, it will not work in plateau iris. It will not work when the lens itself is very thick, but obviously it's going to only work in a pupillary block, right? And then comes our next question is, how do you identify what is a pupillary block? You just need to put in your slit lamp, okay, and see this. Can you see that configuration of the iris? That's a pupillary block, okay? This is on the slit lamp. You can see that there is a convex configuration of the iris, which is so typically a pupillary block. But when you see the whole lens iris diaphragm shifted anteriorly, or because of a thick lens, that is not a pupillary block. That is not going to be relieved with an iridotomy. You understand? So you have to be very wise in advising an iridotomy. It's not an innocuous procedure. There are lots of problems with an iridotomy. And I will tell you those also. So when a PSCS patient comes to you, he has an occludable angle and you have to decide to do an iridotomy. We used to do a lot of these darkroom prone provocative tests. I don't know how many of you have done it or know about it. Can you raise your hands, those who know about it or have done it? No, which is very bad, because we expect the residents to know about it. Okay? Right. So the darkroom prone provocative test is a test where you can identify which of the occludable angles are going to have a high pressure, or you cannot leave them primarily, basically, because they're going to go back and have high pressures, intermittent high pressure. So you should know about it and should have done this test. The one-eyed patients, again, these are high-risk patients, and probably you should err on the side of doing an iridotomy. Those who have a family history of angle closure are another group of PACS patients who could consider getting an iridotomy done. Patients who require repeated dilatations of their eyes for fundus evaluation, either uveitis or diabetes, they again require an iridotomy. Patients who are unlikely to follow up, and then of course there are those which have very shallow anterior chambers which you think can have some problems. Mind you, an iridotomy does not relieve a malignant glaucoma. An iridotomy can cause a malignant glaucoma, but it will not relieve or prevent a malignant glaucoma. That should be very clear to you. We go on to the next stage, which is the primary angle closure. Now, here you've put in a gonioscope and you found that there are synechiae, right? So there are synechiae all over, or the angle just doesn't open up. That means even if you've done an indentation, the angle will not open up, okay? This is also a sign of the next stage, which is primary angle closure. So this, here the IOP can either be normal or it can be high. So in either of these cases, the chances of these eyes going into the next stage, which is glaucoma, is very high. So you always do an iridotomy in this stage, okay, irrespective of what is the indication. You just do an iridotomy here, okay. The IOP can normalize, or the IOP may not normalize, in which case you may require to put them on medical therapy, right, because you do not want them to go on to the next stage. So there was this randomized controlled trial. You have to know, because there are a lot of such trials that have come up in the recent past, where patients were subjected to either iridotomy or no iridotomy. And they found that even with primary angle closure, the patients who went on to a PACG, the percentage was very less actually. So they were not really sure if the iridotomy was actually doing a big deal in patients with PAC. Okay. So the important thing to understand is that even when you are doing an iridotomy, you have to give this counseling to the patient. It could be one of your relatives, I mean, who wants to know whether an iridotomy, I have been advised an iridotomy, should I get it done or not? Again, as I said, you have to look for a pupillary block. That's the only thing that the iridotomy is going to relieve. The primary angle closure glaucoma. If you see this kind of a picture, okay, it's a diagnosis that's staring in your face. It's a primary angle closure glaucoma. Iris is atrophied, it's a mid-dilated pupil, okay, and the intraocular pressure is high. It's a primary angle closure glaucoma, right? And sometimes if you carefully examine, you can see a atrophy of the pupillary rough, okay. Now these patients will come with a glaucomatous optic neuropathy. It's not necessary that their IOPs may be high. Their IOPs, when they see you, might be absolutely normal, 12, 14 and all of that stuff. But when they go back home, that's the time when they have those spikes of high intraocular pressures, in which case they need treatment. Once the glaucomatous optic neuropathy sets in angle closure, you need to treat them, even if the IOPs are coming to be normal, okay? Because you've seen that there is an occludability, you've seen that, that there is a glaucomatous optic neuropathy, so irrespective of the IOP is high or not, you have to treat them. It's a chronic angle closure glaucoma. So the next important thing, in fact the most important thing about primary angle closure glaucoma is how to manage it. So once glaucomatous optic neuropathy has set in a scenario where there is a primary angle closure glaucoma, you have to understand what to do. To do a cataract surgery, to do a trabeculectomy, to do a trab with a cataract surgery. Okay? So this is something that you have to be very clear. So it's a PACG, but there is no cataract. The lens is clear. Okay? If the IOP is controlled on topical medications, okay, so you can maybe leave them as such, because the IOP is well controlled on topical medication. But the IOP is not controlled on topical medications, and there is no cataract. The next thing that you would do is to decide whether to do a clear lens extraction or to decide whether you're going to do a filtering surgery. Raise your hands. There is a PACG, there is no cataract, and the IOP is not controlled on medication. What will you do? This is the central to your understanding of management. So you will do a biometry. Okay? You will look at the anterior chamber depth. If the anterior chamber depth is less than 2.4 millimeters, you would err on side of removing the lens. Right? There is no point. If the anterior chamber is 2 millimeters and you're doing a filtering surgery, you're making the anterior chamber even more shallow. Okay? So the idea here is to do a filtering surgery only if you have an adequate anterior chamber depth. Otherwise, you do a lens extraction. It could be a clear lens extraction in some cases. Then there is another scenario where there is an angle closure glaucoma with a coexistent cataract. Now the IOP is controlled on topical medications. Maybe if there is a cataract, you do a early lens extraction because there is a cataract. But if the IOP is uncontrolled on medications, right? Again, now is a scenario where there is a cataract and there is an angle closure which is uncontrolled on medications. So you have to think whether to do a combined surgery, to do a cataract surgery, or to do a filtering surgery. Okay? So here there are three scenarios. So you have to decide whether to do so what are you going to do? There is an angle closure glaucoma, there is a glaucomatous optic neuropathy, and IOP is not controlled on medications. So it's always good to do one surgery at a time. There'll be people who will tell you to do combined surgery, but combined surgery is not good either for the cataract or for the glaucoma, because eventually the filtering surgery will fail because of the intense inflammation, and the cataract surgery itself will get complicated because there are two surgeries doing. So it's always good to do one surgery at a time. Do your lens extraction if you think that the patient needs visual rehabilitation quicker, okay, or if you think that the anterior chamber depth is very shallow, so the lens extraction takes precedence. However, if the lens is not so anterior, or anterior chamber depth is good, you can go ahead and do a filtering surgery, wait for some time, maybe a month or so, and do a lens extraction later on, right? That's the way to go. So I hope there is some clarity regarding this. So here is a patient, you can see the right eye has got a 0.8 cup, it's a PACG. IOP is 26 on maximum medical therapy, and the vision is 3/60. The left eye is relatively good. So this is a normal, most common scenario with an angle closure, The angle closure will have one eye which is very advanced, the other eye is almost like normal. Okay, so very common scenario in an angle closure, unlike a POAG, where both the eyes will show an advanced cupping. Both the eyes will show an equal amount of some morbidity. But here in angle closure, the morbidity in one eye is much more than the other. So now here you can see that this eye in the right eye, now can you tell me what will you do for this eye? You have this, again, a scenario of a glaucomatous optic neuropathy in the presence of a shallow anterior chamber, and I just told you, pardon? Cataract surgery. Anyone for a filtering surgery? 0.8 cup, IOP is not controlled on medication. So right, you do a lens extraction, early lens extraction, you wait for some time, you see how it responds, maybe the IOP just comes down, and these days we do a lot of lens extractions with an angle surgery like a goniotomy or incisional or an excisional goniotomies we do, and that itself brings down the intraocular pressure. But if it doesn't, you can still go on and do a filtering surgery at a later point. Okay, so this is the better management. Again, there's enough literature on this. What are the factors that will predict the intraocular pressure control after phaco in angle closure glaucoma eyes? So it is the anterior chamber depth. Again, if the anterior chamber depth is more than 2.4 millimeters, it's better to do a filtering surgery. If it is less than that, it is better to do a lens extraction. Now, as far as progression of these eyes is concerned and the long-term outcomes, as I said, the morbidity in angle closure glaucoma eyes is much more than in open angle glaucoma eyes. Invariably, you will see one of the eyes will be blind, like 2/60, 3/60 vision. The other eye is 6/6. Okay, so therefore, the morbidity and the progression rates are much faster in angle closure than in open angle glaucomas. So therefore, it's important to manage these eyes wisely, right? The 5-year incidence from PAC to PACG earlier were considered to be 28%. Obviously now it has come down, and now people do not see such fast rates of progression. Also because of better management of these eyes, more and more patients are getting lens extraction early. So therefore the progressions are much less than they were before. The next important thing that you have to understand is, when you're talking of angle closure, is to understand the genetics of this disease. There's a lot of things going around, but the first degree relatives are almost 3 to 5 times at a higher risk compared to the normal population, and you have to know that the biometric characteristics of these are also inherited. So if there is a patient who's coming to you with angle closure, it's important for you to screen the relatives, which is known as cascade screening. You have to screen the rest, because that's where you're going to pick up maximum amount of glaucoma. if you've screened them. And you must understand that if they have an occludable angles, the siblings have almost 8 times the risk of occludable angles also. Okay, and of course there are genome-wide association studies, and certain genes have been discovered associated with angle closure. So to summarize, basically, iridotomy should not be advised indiscriminately. I've shown you which particular eyes would benefit from iridotomy. Nevertheless, you have to have a high index of suspicion whenever you're dealing with glaucomas, because you have to be able to understand, to be able to do your gonioscopy and pick up occludability. You can be sued if you have not, picked up a occludable angle when it was. You already understood that PACG eyes progress faster, and an open angle also becomes occludable over time. Okay, so what you may see as an open angle now, as the lens thickens, can become occludable over a period of time. And again, as I said, because the ocular morbidity of this disease is almost 5 times that of POAG, the stress has to be more on angle closure and identifying it, in treating it, and in managing it properly. Okay, the complications of managing angle closure eyes may be much worse than the complications that you get while managing the POAG. So that is all about angle closure. Any questions you have, I'm happy to take.
Thank you, Dr. Vinay, for excellent presentation. So one of the important key message from the talk is iridotomy, where we should be doing iridotomy. So all PACS patient should not be undergoing iridotomy. Patient having PACG, iridotomy has to be done. And all PACS doesn't go into PAC or PACG. So we have to be very, very careful. We have to look at the other risk factors before deciding about PI in PACS. Okay. Thank you, Dr. Vinay. So with this, we finish this session. So I'm thankful to all the speakers, and now we break for tea, and we'll come again at 11:30 sharp. Thank you.